Good morning, Chairman and Co-Chairman. Today I will present about the total hip arthroplasty in ankylosis and arthrodesis hip. Well, for the indication for conversion from the fusion hip to the total hip arthroplasty is the first one is the malposition. The second, and the malposition is mean if the patient has reflection of the hip fusion more than 30 degrees or adduction more than 10 degrees, or the patient have any degree of the abducted hip. So the second one is the pseudarthrosis. The third one is the ipsilateral knee problem or the contralateral hip problem. And the last one is if the patient has a persistent low back pain. But the problem of the converting from hip fusion to the hip arthroplasty is a decision-making problem, because if the patient have a severity of the problem, like have a lot of ipsilateral knee pain or contralateral hip pain, you may consider it because the patient will have the benefit and the pain of the hip and knee will be decreased. But the problem is the risk of a takedown of the fusion hip. And the benefit of the conversion that you should consider also. The result of the conversion is depend on the hip abductor. If the hip abductor function of the patient is very good, it is the best result because the patient can walk normally without anything. However, if you convert it and the patient have a problem about a non-functional abductor, converting to the total hip arthroplasty may still help because it might increase some motion. But if the abductor is not good, the patient might have a tenderable gait. And in the worst case, the patient might have a hip instability. So normally we need to assess the abductor function first, whether the abductor contract or not. And are there any previous fusion that disturb or spare the abductor? For example, if the patient has been fusioned with a cobra plate, you need to be careful because the abductor might have some problem. You might need to do an EMG or an MRI. The MRI is for checking the integrity of the abductor muscle. And the EMG may show you that the abductor will work or not. And you need to talk to the patient a lot for the patient expectation, because most of the patients that they want to convert it, they want it to gain motion. Yes, when we convert it, patient will definitely have to gain motion, but may not be normal. Yes, if the patient have the problem with the hip and the knee pain or the back pain, we can tell them that yes, the pain around here will be better. But if the abductor function is not good, the patient may need a gait aid for the rest of their life. The problem of conversion is also about the technical demand. The back posture is the problem, and where we should cut the femoral neck, how to prepare the acetabulum, and about the femoral fixation. For the exposure, if there is no implant around, you can do the conventional posterior or anterolateral approach up to the surgeon preference, but you definitely need to do the inside to neck cut. But if the patient have a retained implant or have the fusion, like for example the cobra plate, you might need to do the transtrochanteric approach, because the hardware, if you can't remove the hardware before, the hardware will blocking the neck cut. And if we want to do the posterior approach, but the hip is the external rotation position, you will definitely can't do that. So the internal rotation or the external rotation of the hip might tell you that some approach you can't do. For the femoral neck osteotomy, you need to get the correct level, cut at the correct angle. So you need to do the preoperative planning and cut it as you plan. And In some cases, you may need to use a fluoroscopy to make sure, confirm the cut and angle. And you have to leave some bone on the acetabulum because you need to reaming, and that will be the landmark that will let you know that where you should ream and going in. For the acetabular preparation, the problem is the short anatomy. The patient might have the flex or pelvic tilt. The landmark is the same as we do the total hip arthroplasty for the ischium. Look for the teardrop. Confirm it is a fluoroscopy if possible. And for the depth of the reaming, you just see whether it's white out or you use a drill and the depth gauge. For the cuff fixation, you have to consider it like a revision acetabulum because there's an osteopenia around here, and you need to prepare like the multi-hole cup. And beware of the pelvic tilt because the position of and the placement of the acetabulum is crucial, especially in the ankylosing spondylitis because the patient will have the pelvic tilt. And if we place it in the wrong position, there might be a dislocation in the future. For the femoral fixation, it's quite straightforward, except if the patient has an instrument before. If the patient has an instrument before, when we remove the implant, it will be a little bit difficult. For the postoperative management, just protect the weight bearing as need, depend on the implant fixation and trochanteric status. And in all of this case, you have to prevent the dislocation because the abduct function might not be good. And don't forget to prevent for the heterotrophic ossification. For the result of the conversion, there's quite a paper, like both of the papers published in the 2011. One paper, they say that every score is quite nice and the survival rate is quite good, and publishes in the same year, totally different. In this paper, you see that every score, every WOMAC, Oxford, and mean classification score of the takedown fusion is less than the primary total hip arthroplasty. Also, for the 10-year survival rates, dropped down only to 74%. So for the systemic review, they say you will see that in most of the case, when we convert it down, there's a higher risk in everything: infection, instability, loosening, nerve-related complication, abductor-related, and a lot of cases had to do the revision. So in the conclusion, discussion with the patient about the patient expectation is the most important thing that you have to do before you decide to convert it. And when you decide to do it, it is a very technical demand operation. So you need to be prepared very well. And the last thing is, when we are already surgery, you might have to do something more in the future because they have a lot of complication rate. Thank you very much for your attention.